Good evening to everyone. Dear esteemed colleagues, I am Dr. Charlene, Secretary for the Spice Group Young Doctors Movement, and I warmly welcome everyone to our GP's Cafe today. So today is special because we can actually see other faces as it's hybrid, and it has been an interactive session today. So let's move on. Tonight, our guest speaker is Dr. Halpe. And a lot of us know him as a very enthusiastic doctor with a lot of ideas. He's a graduate from CITEM, and also he's a registrar in family medicine and also an MCGP trainer. So over to you, Dr. Halpe.
Thank you. Okay. Good evening, ladies and gentlemen. So my name is Shane Halpe, and today I'll be talking to you about one of my experience in my general practice career. And without further ado, let me share my experience with you about a patient whom I have seen, who was hiding in plain sight. So the story, how it goes, is Mrs. J, I would call her, a 52-year-old mother of 4 children. She presented with a gradual onset of generalized body aches for 3 months. And she also complained of on and off headaches and multiple joint pains, including backache, bilateral shoulder pain, and knee pain as well. Over the 3 months duration, it was progressively worsening. And these joint pains were relieving at rest, and it sort of gets worse while at work. However, there was no morning stiffness. And she also mentioned that she feels tired easily. And with that, she has a poor appetite, and she had lost weight, but she can't remember how much she had lost weight, but she says that she had lost weight. And however, there was no fever. And on further inquiry, she also complained of poor sleep for about 2 months, only sleeping for about 4 to 5 hours a day. And she goes to sleep at around 10 or 11 and wakes up at about 3 a.m. She had no neurological symptoms, and also she didn't complain of chest pain or palpitations. And she did not have a chronic cough or shortness of breath, and there was no abdominal pain or change in bowel habits. Furthermore, there was no change in urine output frequency, and the amount was normal as well. On past medical and surgical history, she had a multinodular goiter with thyroiditis for a duration of 4 years. And the FNAC was done, the results were inconclusive. And along with that, she also had migraine, and she was taking treatment for bronchial asthma, dyslipidemia, and once treated for urinary tract infection. And she was only on Esteline inhaler SOS, and also Seretide, which she was using regularly, twice a day, and atorvastatin 10 milligrams noctate. And she did not have any allergies. And her menstrual history, she was menopausal, and gynecological history was also not significant. And a pap smear was done at the age of 40. It was normal, and she was not on any contraceptives. And family history, she did not have any records. That's because she did not have any living member of her family, and she was an orphan. And her social history goes like this, where Mrs. J, she's living with her partner, and now this partner is from her, from the first marriage. Her first husband, he passed away, and she had 4 children from her first marriage, and she was working as a cook at a government-owned holiday bungalow. And she did not have any history of substance use or smoking or alcohol. So at this point, so I would like to invite you to contribute. So this history, do you have any thoughts about what she might be having? Because she did say about multiple joint pains, and she did say complain of loss of weight and loss of appetite. So any thoughts, you can contribute? Okay, that's a good thought. Sorry? Yeah, thyroid dysfunction, yes. Fibromyalgia, okay. That is, yeah, sorry. Polymyalgia rheumatica, that can be entertained as well in this age. Chronic fatigue syndrome, yes. Especially if there's a history of preceding viral infection, COVID especially, yes. Yes, diabetes mellitus could be masquerading. We don't know. So, so I will move on. And so hyperthyroidism, so when I was talking to this patient, Mrs. J, I thought about hyperthyroidism as well. It could be hypothyroidism, and maybe a thyroid malignancy, because history of the multinodular goiter and loss of weight and loss of appetite. And maybe just simply, she was going through menopause, but I put it lower down in the list because it was 2 years. And rheumatoid arthritis, also I was thinking about it. And tuberculosis, because, but then again, she did not have a cough, but it could present in many ways. And diabetes mellitus, surely. And before I move on to the next slide, I just want you to look at this, picture. It's called the sunflowers. So this was originally painted in 1889, right? And this portrait, I saw this painting in the National Gallery in UK. So anyone know who the painter is? It's a famous painter. Yes, absolutely. Vincent van Gogh. So I want you to think about Vincent van Gogh, because there's a slight relationship, to our case. Vincent van Gogh has a connection. Sunflowers. So this is the next question I asked. After asking all about joint pain and medical history, social history. So just before ending my history taking, I just asked, are you happy or are you sad? Well, of course I asked it in Sinhalese. And then this is what happened. Doctor, I'm feeling sad. She opened up. And then she said, I have no interest in anything at all. My life is not worth living anymore. And she said she's very irritable. She's very anxious about everything. And she gets startled to the slightest noise at home, maybe like a dog barking or maybe a cat, maybe like a door being shut. She gets startled. And sometimes she said that she cries if the partner, talks to her in a loud voice, and she started crying. And then came the breakthrough information. She had attempted suicide 3 times. And she told me that she had, first attempt, she had taken 10 tablets of paracetamol, but she hadn't told anybody. And she, basically that was the first time she told me that she had taken 10 tablets of paracetamol, and I think 10 tablets maybe it wasn't toxic. And then the second attempt was, so she's living by the seaside. She had just gone towards the seashore, and then she had thought, okay, I'm going to die. I want to get drowned in the sea. And then there had been onlookers, and then the onlookers had rescued her when she had gone somewhat into the middle of the sea. And the third attempt was she had attempted hanging while at home. And when she got onto the chair, and then when she tried to put the noose on her neck, there is a child, living, the child of the partner whom she's living with. And then this girl had shouted, and then the partner had come running in, and the door had been locked, but he had broken the door and somehow rescued her from that attempt. So this suddenly she started, and then it's like, gosh, it's all opened up because of one question: are you happy or are you sad? Social history. Then again, I took the social history, because I only took only a little bit of information. And then she said that she had 3 daughters and 1 son, and her daughters are all married. And after getting married, because of the influence maybe of the son-in-laws, they have chased her out of home. And they have also demanded her position and whatever the income she's getting from her workplace. And because she was not willing to share all her income, basically one day when she had returned home, all her bags and baggages were outside, and she was not allowed to walk in. And then nowhere to go, she had returned to her workplace. And the supervisor, being kind, opened the doors for her, and then she had temporarily lived there. And then she had moved to her partner's home. And then for about 2 to 3 months, there was absolutely no contact with her children. And which hurt the most was her son, who's at that moment he was sitting for the O-level exam. Even the son was not talking to her because of the influence of the sisters. And then the first husband had passed away during the tsunami, and the new partner is actually ex-rebel cadre, but who he had given up his ways, and now he's settling down. And also he had a child who was differently able, daughter of 8 years old, and no one to basically take care of her. And then they have started to live together. And then and that also had influenced Mrs. J's daughters to basically chase her out of their home, because they were very upset that her income is not coming to the daughter's side. And then so this is her social history, which I retook. And then I also explored the ideas and concerns and expectations. And then she had no idea what's happening. She was wondering why she's getting sick, and is this sort of a thyroid cancer because of the goiter she was having. And her main concern was, my children have left me, I have no one to live for. And her expectation was to basically sort out this problem and why she was having all this, and if possible to be reunited with her family. On examination, there was not much significant findings. Thyroid gland was prominent. There were no palpable nodules as such, and no retrosternal extension, and no cervical lymphadenopathy. Her BMI was in the normal range, and she was not pale. Her pulse was 80 beats per minute regular. There was no arrhythmia. Blood pressure was normal. Heart sounds were normal. No cardiac murmurs. Lungs were clear. Abdomen was soft, and the cranial nerves, upper limb, lower limb examination was normal. And her mental state examination, which I don't do regularly, but in this patient I did. Her appearance was normal, right? There was nothing wrong looking at her, and she was, well kept, and she was maintaining eye contact. Her speech, amount, rate, and volume is normal. Maybe the tone was monotonous. Her mood was obviously low, and thoughts. This was after, at the latter part, I figured out that she had suicidal thoughts, and she was worried about the future, and she was hopeless. And she also had the hypnagogic and hypnopompic hallucination, which means hallucinations which occur at the start of going to sleep, and at the end of sleep when she wakes up. It is sometimes a phenomenon which can be observed in depressed patients. So she had that, but there were no delusions, and there were no visual or auditory hallucinations during the time she was awake, and she was oriented, and she had good insight, and insight as in she did not know what was going on, but she is willing to undergo treatment. And then these were the two investigation results she showed me. Ultrasound scan of the neck, which had features of a multinodular goiter with background acute thyroiditis. There were no features of malignancy, and FNAC was done, and which showed the Thai-1 inconclusive result. So these were the problems she had. I found her to have a low mood and suicidal thoughts for 3 months. She had a multinodular goiter. And the third problem was probably the biggest problem. She was socially isolated. And also the chronic problems of bronchial asthma, dyslipidemia, and migraine. So I applied the DSM-5 diagnostic criteria in this patient. So I have pointed out here. Well, she had a depressed mood most of the day, and she had markedly diminished interest or pleasure, and significant. Actually, she did not have significant weight loss. One thing is, it was not recorded, but she had a decrease in appetite nearly every day, and she had insomnia. However, psychomotor agitation, it was not something I was able to elicit. And she had loss of energy, and she had feelings of worthlessness, hopelessness, and ability to think or concentrate was not something I was able to elicit. And she had recurrent suicidal thoughts. So when I applied, says that 5 or more of the following symptoms were present for more than 2 weeks. And because of that, I came to a conclusion that this could be a severe depression patient. So one of you also said that straight away the first answer was depression, and then happened to be that. So what I did was actually she was coming from a remote area, and then I was not able to start treatment. And also the fact that she had suicidal thoughts, I had to refer. So I did some initial counseling for her, and also the fact, the importance of taking treatment, and also to attend a nearest the psychiatric clinic, and then I referred her appropriately. And then and she was seen by a psychiatric medical officer. And then because in that hospital there were no consultants, and then she was started on imipramine 50 milligrams Noctane, which was increased to 100 milligram Noctane, and also on clonazepam. And very rightly, the medical officer had started had brought down the family members, and he had spoken to them to especially look after their mother, and also the seriousness of this problem she was having. And also I advised her to be followed up for the multinodular goiter, because the FNAC only showed it showed a type 1 type histology, and it could change. So to do a repeat FNAC, which they have suggested, and also to do a TSH. So this was what had happened, and then they have diagnosed her as a patient with severe depression and suicidal ideation. And some of the follow-up investigations were done, and they were all happened to be normal. And also FNAC, the repeat FNAC showed a benign thyroid lesion, which was very reassuring. And her fasting blood sugar was normal as well, and TSH was normal as well. So let us open up the forum for discussion. So GP's Cafe is open. So if you have your cup of coffee, please take it up and let's discuss. I would like to hear your thoughts. And this is my experience of a patient, managing a patient with multiple somatic complaints. And so I would like to hear your thoughts. Yeah, so one thing is, so discussion is also open for the all of you who have joined us online. So please you can voice your thoughts or put it in the chat box. Yeah, and so the question I got was that whether is it appropriate to ask whether you are happy or sad, and whether now we have start on the morning, and the thing is that when most people say that how to differentiate the whether we need to get concerned or just it off. Yeah, when if we ask, so the question was, if we ask a patient whether a patient is happy or sad, will we get the correct answer? Because almost everyone may say, doctor, man duken inne, ari upset එකෙන් inne, because of the obvious reasons which we are going through. I mean, economic crisis or political instability or whatever problems we are having. Well, yeah, I mean, in this case, it worked for me when I asked that question. Yeah, again, I'll repeat the question. In whom should we ask whether you are happy or sad? Isn't it? I mean, because you can ask it, right? I doubt that as the percentage that they see that so either we ask it repeatedly or we request more that we ask that, and then from there we build up Let me move on. Yeah. Yeah. To answer your question, actually, whether how to really, in whom should we screen and what should we ask for, actually, this article which I read, got it from the American, they recommend to use the PHQ for depression. So basically, actually, they recommend in every patient, at least once a year, to ask these questions, right? Any patient, the age above 18, and also to the geriatric age group, you may ask, over the past 2 weeks, how often have you been bothered by any of the following problems? The problems could be little interest or pleasure in doing things, and feeling down, depressed, or hopeless. So only 2 questions. And so to those questions, the patients may say either not at all, or sometimes, or every day. I think if depending on the answer, I think that would raise a red flag. And I suppose in general practice, we will not be seeing the patient only one time. And depending on the relationship we develop with the patient, and the patient will come back to you. And depending on the trust they have, as time goes, we could be able to ask that question. So, so that is the suggestion I suppose we could adopt as general practitioners. Not in every consultation, whether you are asking whether you have lost interest or whether you feel depressed, and then that patient will also think that the doctor is might be having depression. And also you may use the PHQ-9 also. If the PHQ-2 is positive, then maybe we could go another step further and go for the PHQ-9, which have more questions, maybe to strengthen or consolidate our screening. So little interest or pleasure in doing things, feeling down or depressed, and trouble falling or staying asleep, feeling tired, poor appetite, feeling bad about yourself, that means guilt, trouble concentrating, and moving or speaking so slowly that other people could notice, and thoughts that you would be better off dead or hurting yourself. So I mean, you could ask these questions and use the PHQ-9 screening. And so that is, I suppose, as general practitioners, we could adapt, isn't it? And I'm sure almost all of you would have met patients with multiple somatic complaints, and it could be many things. And so the lessons I learned was after thorough history taking, simply, and especially the importance of taking a very thorough social history, psychological history, things like that. Sometimes which we may not have the time in our busy clinical practice. But if we have the time, if we are able to ask these questions, we might be saving a life. And also, this encounter helped me to establish, strongly in my mind, the principles of family medicine, especially establishing a reason for encounter. Because the patient came to me with a presenting complaint of generalized body aches. But her reason for encounter was something else, malignancy, and why is she sick, and also the underlying diagnosis was something totally different, which she was not aware of. And also the importance of holistic care, to have a holistic approach. I mean, she obviously, she was having asthma, and she had dyslipidemia, and she had multinodular goiter, which needed follow-up. And so many issues. I mean, it's, I mean, lot of issues for us to deal with. I mean, more than enough for a medical doctor or general practitioner to deal with. But if we have a holistic approach, we might be able to do a better job as well. And comprehensive care, basically not only address one thing, but address everything. And continuous care, so that means to follow up, to see her again. And appropriate and prompt referral. Because it would have been wrong of me to start treatment on my own, because this is the case of severe depression. And just briefly about management. So in severe depression, we should start treatment with antidepressants, such as SSRIs, like fluoxetine, and TCAs, tricyclic antidepressants like imipramine, or SNRIs like venlafaxine. And we have to continue these antidepressants for 4 to 6 months. In the full maximal dose, or the adequate dose, and then we could consider either tapering it. And we have to educate the patient about the importance of strictly adhering and not missing the antidepressants, and also hypnotics in the short run, such as clonazepam or alprazolam, to help deal with the anxieties. And psychological therapies could be cognitive behavioral therapy, counseling. And patient and family education is also important, where the psychiatrist had appropriately done and brought down the family members and educated. So referral, in whom should we refer? So emergency referral in the risk of suicide, danger to others, and psychosis, in this case, was an emergency referral. And routine referral if failure to treatment in the primary care setting, so that we don't need to maybe hurry up, but we need to refer. And patients with other medical comorbidities, for example, if the patient is having like ischemic and so on, because there can be a lot of
Dr. Shane, sorry for disturbing. There's another question on the chat box.
Or TCS.
So someone wishes to know if we are diagnosed of depression, do we refer ASAP? Do we start treatment ASAP or refer?
Yeah, we should start soon as possible because of the risk of suicide. And in this patient, of course, it was very simple because of the suicidal ideation. I didn't think twice and immediately I referred. I could have started the treatment as well, but because she was coming from a remote area and he was not able to regularly visit me in my clinic, I thought the best thing would be to immediately refer. And I also spoke to the doctor over the phone that I'm sending a patient like this. So then that way I was able to liaise with the psychiatrist. Otherwise, I think you do have the. My opinion is we do have the. Any other questions?
That's it.
So epilogue, I mean, at the end, what I want to share is this patient is now clinically stable and there was no suicidal ideation, and her mood is now euthymic. And she did complain of on and off insomnia and anxiety. And now her son is frequently visiting, and which is a great source of joy for her. And she does not feel hopeless or worthless now. And now she's, I mean, currently occupied and doing her work. And then she's been regularly followed up by the psychiatrist at the local hospital. And these were my references from articles from the family physician, the handbook clinical psychiatry by Dr. Kapila Ranasinghe, as well as to Dr. Sankar Ranjani Kumar and Dr. Tivanka Munasinghe, who is my mentor, and from NCGP, and then my gratitude to the Spice Route, Dr. Gobit Ratnam and Dr. And they was able to see, and then only that patient came to me, and then was able to.
Thank you, Dr. Shane. That was very interesting. And I would now like to invite Dr. Bobit, the chairperson of Spice Route, to give the certificate. Okay, so now we close the session for today. Thank you to all the participants for joining us today. I hope this was very interesting and everyone learned something out of this. Thank you. Good night.